Always find joy in the smallest of things. That is what we found in you. Oh, 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 you are joy. Never give up when the going gets rough. Hope is everything you need. Oh.
Hello, my name is Asim Shah. I am a psychiatrist and I work for Baylor College of Medicine. I'm professor and executive vice chair in Baylor College of Medicine Department of Psychiatry. I'm also the chief of psychiatry for Ben Taub and Harris Health System. Today we're talking about mental health. We're talking about mental health in young folks, whether they are teenagers or early teenagers. And we're also going to talk about the mental health scenario with specific relationship to different religions, different ethnicities, and different cultures. Mental health is something which is very near and dear to me. Why? Because I feel that this is something which is ignored. There's a lot of stigma with mental health. Even the word mental health has stigma in it because the word mental creates stigma. So I try to often call it by a name called brain health or psychiatric health as opposed to mental health, just to reduce the stigma. Why mental health is important in this state? Texas is perhaps one of the most underserved or uninsured population state when it comes to physical illnesses and especially mental illnesses. So that's one. We also want mental illness and we also want people who suffer from mental illness to not have any hindrance in terms of care. So for example, if you don't have any money, you still need to be able to see somebody who can give you some help, who you can see and approach help. Now, help is important, of course, but help is important at the right time. So access of care is important, but early, easy access of care is the most important thing because you don't want to see somebody once you have full-blown symptoms and it is a little too late, so we don't want that. Why it's important in kids? Why we talk about it in young people? First of all, over half of the psychiatric illnesses start before the age 18, actually before the age 14, so that's important. Substance use, if you think about substance use, which about 60-70% people who have mental health do have substance use issues. Substance use is very common and it starts, at least 25% of substance use starts before the age 14 also. So we need to talk about mental health with the young age because these things start at a young age. Secondly, if you look at the full-blown episodes of psychosis, of mania, they usually happen in teenager group, 18, 20 or early 20s. So that young population, that high school population or that early college population is unfortunately the target age when these full-blown psychotic symptoms or manic symptoms happen. And if we don't know what we are looking for, we are going to miss it. Thirdly, if we talk about suicide, which is the most serious complication of mental health, suicide is the second leading cause of death in ages between 14 and 24. And some people say even in ages between 14 and 34. So that also is a big problem. And just a little bit about suicide. Every year in this country, about 45, 46, 47,000 people die of suicide. That's a big number. Half of them hurt themselves because of a firearm, which is another debate, but again, access to firearm, if somebody has psychiatric symptoms, can be a problem because with firearm usage, there is very little chance of a person surviving. We also have each year about 250,000 or 250,000 people who survive suicide. The number one predictor of suicide or a future suicide is previous suicide. While we need to worry about the 46, 47,000 people who die of suicide every year, we also need to worry about people who survive suicide, the 250,000 who survive suicide each year. Why? Because that is the number one predictor of a future suicide. And if we can save some of those lives, that is always a very good thing and that is very beneficial. So that's something important also. Substance use. Substance use is extremely common. Some people don't think that alcohol is a drug of abuse. Some people don't think marijuana is a drug of abuse. Some people feel that marijuana is legal. It's not legal in Texas, so not for us at least. And the other problem with these substances is that whether it is marijuana or alcohol, they can be gatekeeper for other hard drugs. So let's start with substance use. Alcohol. Alcohol in mild quantity may be okay, but when people drink, sometimes they don't remember that they're drinking more and more and more. And what we say is that anyone who is drinking more than 4 8 ounce of beer or so every day, that could be something of a concern. And if you're drinking more than 14, 8 to 12 ounces of beer in a week, and if you're a female, more than 7 in a week, that could be a very dangerous sign. Why less for women than men, or female than men? Because the threshold of tolerance is less in women than in men by nature. So we have to be careful about that. Marijuana is another thing. What marijuana does to young people, it causes amotivational syndrome. People who use marijuana decrease their motivation, and people say that it relaxes me. And yes, it does relax you, but it relaxes you a little bit too much that you don't care about things. Certain amount of stress is always good for life, because stress is a motivator. Stress motivates you to do things. But if you don't have any stress, any urge to do things, you become kind of immotivational. So marijuana does that. Of course, marijuana and alcohol are very common in Texas, but after marijuana and alcohol, if you're talking about Houston specifically, cocaine is our third commonest drug of abuse in Houston, whether it is crack or cocaine. If you are in a countryside, whether it is Lubbock or small areas, meth becomes more common than cocaine because it may be cooked in the backyard. And then after these 3 or 4 drugs, we have PCP, which is relatively common, Kush, which is relatively common in our state, in our city. Then come prescription medications. People tend to use a lot of prescription medicines, and some tend to abuse them. Xanax is the prime example. People buy it from the street and abuse that. People abuse pain medicines, Vicodin or so, muscle relaxants. And young people also tend to abuse stimulants, whether it is Adderall or any other stimulant. And they feel better, and they feel that they're able to focus and concentrate with that, and they want to take more and more, and that could be a problem. So we need to be careful about that. Now, back to psychiatric illnesses. Depression is, of course, the most common psychiatric illness. Over 20 million in the country suffer from depression, and there are warning signs and symptoms of depression. So the commonest warning sign and symptoms of depression would be losing interest in things. So if you are a person who enjoys playing sports, games, or watching TV or hanging out with your friends, if you're not doing any of that, that means that you have lost interest in activities you used to enjoy. That's the number one warning sign and symptom of depression. So lack of interest or not enjoying things is one. Then it is combined with the depressed mood, combined with the lack of energy, and those things all are symptoms of depression. In addition, some people sleep less, sleep more with depression, eat less, eat more with depression. Those are non-specific symptoms, but happen too. So in short, if you're thinking about depression and how to diagnose depression, think about a person who has lost interest in things, who is depressed, and who has no energy. As opposed to depression, there is another phenomena called mania. In mania, people have tons of energy. They have a lot of energy. They are unable to sleep, and they are all over the place. So if you think about mania, it's too much energy and inability to sleep, and then you act erratically, you are irritable, maybe talking too much, too fast. That would be mania. If you think about psychosis, psychosis is one of those diseases in which people not only hear voices and see things and feel people talk about them, they have impaired reality testing. How do you define that? Impaired reality testing is a phenomena in which a person is unable to separate reality from what is unreal. And the classic example of that is that anybody who wants to know what psychosis is, I recommend them to watch a movie called by the name Beautiful Mind, in which it separates it very easily what reality is and what is not reality. Because a lot of people do hear voices even in depression, but they understand that this is a voice they're hearing and there is nobody there. That's not impaired reality testing. In psychosis, people cannot separate that, and that becomes a problem. Why do I mention that? Again, 18, 20, 21, those are the age groups when manic symptoms start or psychotic symptoms start, and a lot of time depression starts. So we need to be very careful and try to get people help when they have these symptoms. One more thing to remember is that people try to hurt themselves, and self-harm is another issue. So why do people harm themselves? One thing which comes to mind is a lot of times, especially in women, it can be in men also, but a lot of time in women or girls, they may have a history of perhaps PTSD or some kind of abuse, whether it is physical, sexual, emotional, or all three together. And they feel abandoned, they feel neglected, And when they feel abandoned, when they feel neglected, when they feel that nobody cares for them, sometimes the only way for them to feel themselves is to self-harm. And in particular, I'm talking about cutting or slashing their wrist when people repeatedly cut themselves or have cuts on their forearms or their legs and so forth. That is the most common cause of self-harm young people tend to do. It happens a lot in borderline personality or cluster B traits, which happens because of a prior history of some sort of abuse. Therapy is the best treatment for that. Medication may not be the best treatment for that. Therapy may be the best treatment for that. And then there are other self-harm ways people do. People can hurt themselves with other means of suicide, but the most common self-harm means is what I mentioned, which is slashing their wrist or cutting their wrist and those kind of things. A lot of these things happen to people when things are not going their way, when they feel abandoned, when they feel nobody is listening to them. So in some way, if things are going their way, their mood may be better, but if they're not, the mood can suffer and self-harm can be a result. Now, if a young person is affected by any of these symptoms, what do you need to do? Do you need to give them medications? Do you need to provide therapy? Both are fine. Therapy is something which is very good, especially if done in the right way. So therapy with the experienced psychologist can be one of the best options. But therapy demands commitment. You have to see the therapist maybe once a week, maybe even twice a week for 8, 10, 12 weeks, or maybe even longer. So there's a lot of commitment needed in therapy. If you're having therapy once a month, that's not going to change the course of your illness. If you cannot commit to that 12 or 16 week, perhaps therapy may not be for you. Certain diseases improve better with therapy, in which borderline personality is one of them, that therapy is perhaps the keystone for treatment. And then if you think about medications are in some ways a rather quicker way in some people because they don't have to commit to seeing somebody on a weekly basis. But therapy in conjunction with medicines would be the key. Medicine alone should not be the best course of action. What kind of medicines we can use? We can use antidepressants if somebody is depressed. They also help in anxiety. 2/3 of the people with depression do have anxiety, and 2/3 of the people with anxiety do have depression. So SSRIs, SNRIs are a group of medications which can help both scenarios. Then if a person has psychosis, we can use antipsychotics. They work rather very quickly, and psychosis can be treated rather very quickly, but you may have to continue the medication. Then if somebody is manic, we have mood stabilizers which can be used. So today, in today's day and age, we have a lot of good medicines which can be used, and these medicines help a lot of people, and a lot of people get help by continuing to take the medicine. One more thing which is rather common in young people is eating disorder, anorexia, bulimia, and people don't think about it. So some teenagers, some young adults do have an image of themselves that they start feeling that they are a little more obese than what they are. So if their weight is 90 pounds, they still feel that I'm more fatter than somebody else. So their body image is distorted. And because of that, they start either dieting, eating less, or if they binge eat, then they try not to eat to cover up, or sometimes they throw up also, called bulimia, meaning put their hand in their mouth and throw up, forced vomiting, called bulimia. These disorders are also very common and can affect men and women both, more usually women than men, but can affect both. And they're treatable, but therapy is the cornerstone of treatment for these disorders also. So in short, adults, young adults, teenagers can suffer from depression, can suffer from mania, can suffer from psychosis, can suffer from anorexia, can suffer from PTSD, post-traumatic stress disorder. All these can happen. The point is that our goal is to identify these disorders at an early stage, not only identify, get them access to care, get them treatment, and continue the treatment. We cannot avoid treating these disorders because if we do that, that causes impairment in their functioning, and that can cause complication, and one of the complications can be suicide. So we need to be very careful. Similar thing happens for substance use. While substance use is common, help is available. We can get them help, access to care. And not only that, if family is supportive, they are able to get rid of their substance use. In terms of suicide, there is a 1-800 hotline for suicide, which is 1-800-273-TALK. Anybody can call anytime. and that is available, and they can try to connect you and give you resources and try to help you over the phone and decompress your emotions. All that is available through 1-800-273-TALK. Another topic which is rather very common in young people, people of school-going ages and teenagers and young adults, is bullying. Bullying is something which is more and more common these days, but people still don't accept it. There are different kinds of bullying. First is bullying which happens in school or college, meaning in-person bullying. Then there is cyberbullying, which is becoming more and more common, especially during the era of COVID, because people are at home. So a lot of these things are happening through social media called cyberbullying. So first is, who is a bully? Bullies are usually people who are within themselves insecure. They are weak people, and they project their weakness by attacking somebody else who they feel is vulnerable and weak. So for a bully, target would be anyone who they feel is weak and they feel is vulnerable. So first rule of bullying is that if you feel that somebody is bullying you, you can stand up, you can stop them and not show any weakness, even if you have a weakness. Second thing is, people talk about that maybe parents need to confront the bully and so forth. Usually studies have shown that if you find out that somebody is bullying your child, it's best for parents not to confront the bully. Parents need to go to the school authorities. Parents need to talk to a school counselor or school principal, let them confront, be out of it. Because if they confront the person, the bullying can increase to that child. So best is to approach the school authorities. Lastly, we all need to open communications with our kids, because when bullying happens, a lot of time kids don't talk to parents, and that should not be the case. So the best scenario would be that if you know your child is showing some signs which are different than normal, child is quiet, child is withdrawn, child is not doing things, child is not wanting to go to school, whereas the child wanted to go to school before, not going to see their friends, whether they used to like that. So that's a change in their behavior. If parents see change in the behavior, this is the time parents need to explore that. And one of the ways to explore is to try to talk to them, open communication, and say, please, if anybody ever bullies you, ever talks to you bad, whether it is cyberbullying, social bullying, or school bullying, or college bullying, discuss with them. You can teach your child to be strong enough to stand up to a bully. You can teach your child to ignore that bullying. And one easy way to stop bullying is to ignore it, because when they feel that you are not giving into it, they tend to find another target. Unfortunately, they will find another target, but it may not be you. Sometimes it's easier said than not that ignore it, because it could be so harsh that you cannot ignore. But please talk to somebody, either if it's school authorities, college authorities, your parents, and parents need to talk to their kids and educate them about bullying, that if that happens, help is available. Because if we don't pay attention to bullying, it can cause a lot of problems. In some cases, it can be even very dangerous with complications. So please look into those and try to get help for those people who are bullied.
Hello, my name is Jane Barnes. I'm the CEO of the Memorial Hermann Prevention and Recovery Center, better known as PARC, in Houston, Texas. We are located at 4043 Gessner. We offer all levels of care for substance abuse, for adolescents and adults. We have a detox program here. We have a residential program here. We have day program and intensive outpatient services. We also have 6 intensive outpatient services located throughout Greater Houston. Our primary focus is to help addicts recover from addiction and find resources to continue in a road to recovery.
Hi, my name is Stacie Allphin, and I'm the Director of Program Services for Memorial Hermann Prevention and Recovery Center here in Houston, Texas. We offer a variety of programs from adolescent all the way to adult, inpatient, outpatient, and even some specialty programs. But I'm going to let Traci talk about those.
Absolutely. My name is Traci Gauen. I'm a licensed chemical dependency counselor, as well as a licensed professional counselor. We offer all levels of care, starting from detox to residential to day treatment and intensive outpatient. We serve the adolescent population starting at age 13 to age 17, and we also address the adult population as well. We have different tracks at our facility. We have a pain recovery program, and this is tailored to individuals that struggle with chronic pain that may be addicted to pain meds. So we help patients manage their pain without using intoxicating substances. We offer them different coping skills they can use in lieu of using those drugs. We also offer a professionals and executive track as well. We also serve the young adult program, and that's typically ages 18 to 24. So as you can see, we offer a wide variety of tracks, which vary depending on the need of each patient. We offer a individualized treatment plan as well. So we meet the patient where they're at, we ask them what their goals are, and we make the treatment plan tailored to their needs.
In addition, we use a variety of modalities, including action methods, CBT, DBT, we use hypnosis, EMDR, a variety of avenues to help that person get whatever it is that they need from treatment.
Exactly. And for our pain recovery program patients, the patients that struggle with chronic pain, we offer yoga, acupuncture, biofeedback, physical therapy. We teach patients, that motion is lotion. A lot of our patients are really fearful of their pain going up once they stop taking their meds. So this is a really good place to learn how to manage your pain without using drugs or alcohol to cope.
So PARC is a 12-step philosophy-based program, meaning that we believe in complete abstinence as opposed to a maintenance or a harm reduction approach for people that suffer with addiction to mood-altering substances.
So for the psychological part, we see a lot of our patients self-medicate any depression, any anxiety with drugs and alcohol as well. And to address the environmental aspect of this disease, we really encourage patients to build a sober support network. For our adolescent unit, we recommend that our patients go to a recovery high school. It makes it a whole lot easier if you're around people that are doing the same thing. You're more likely to engage in that behavior as well. We also recommend that our patients get involved in alternative peer groups. That provides a really good way for support for the patient as well as the family. So the parents get support from parent support meetings, and the kids get support as well. The bottom line, I believe, is that the adolescent population really thrives on structure. So the more structure that you have, there's no what are we going to be doing today? And I really think that the adolescents really thrive on having a structured daily activity schedule. So it's really important for kids to come to treatment that they really follow our daily schedule. And really the things that we teach the patients here, we want them to continue doing those day-to-day activities outside.
Our adult program is awesome. So we have several different types of programs within our adult program. So we have the professional and executives program, which is really geared for those professionals that may have certain licenses on the line. Maybe that you're part of, maybe you're a lawyer, you could be a physician, the nurses. We've had a lot of teachers, a lot of different executives in all kinds of companies. Anybody that you can think of, we've probably had someone from that company. So we're really good at helping those people get back on track, working with whoever maybe their peer assistant board, so to speak, for their licensing, to help them either remain in their profession, hopefully, if that's going to be a good environment for them, or sometimes they need to make a decision to make a change. And so we are just there to help them facilitate and work through whatever those processes are. The majority of people obviously want to keep the career that they've spent all this time, developing and building. So that is our main goal, is to help them get back to a place where they can function in a really safe and productive manner and to have a happier lifestyle. People are so amazed when they leave that program at how many things are tied to the relationships throughout their lives. They really they lose sight of that in the success and in the use of whatever that substance is for them. So that's our P&E program. And then the young adult program is awesome because we have really spectacular counselors for that particular age group. They do some very different things than the other adults. It's much more peer driven, and because peers listen to peers, that's how it works. So they do a lot of role play. Sometimes they'll come up with skits and perform for the entire facility. They do music. They do just a wide variety of different activities, including working out with our own fitness guy who was on the Ninja Warrior show. So that was really cool. So they get competitive, and we try to make it fun because life is supposed to be a little bit fun too. So if you're not going to be having fun in sobriety, what would be the point of continuing? So there's a lot of that. And then with all of our other programs, people are getting individual sessions, they're getting family sessions. We have a family program that is as good as any other, if not better. I would like to say it's way better than any other program out there, because we really want the families to be involved, because this is not just a stressful time for a person who has addiction issues or anxiety or depression or whatever other mental health may go with that. The family takes a beating at times. They feel helpless, they feel hopeless at times, and our job is really to help empower them in taking their life back so that they can support their loved one in a different way than what they've been doing. So there's many facets to mental health and addiction, and really they're so woven within each other. And it really takes a village. It really does. You need everyone to be as invested as the family is invested.
Some questions that you may want to consider if you're contemplating whether or not you have a substance use disorder is maybe if you have any withdrawal symptoms when you stop taking drugs or alcohol. Maybe it takes you longer to get high or longer to get intoxicated. That could be a symptom of that you're developing some tolerance as well. If it's interfering with your daily life, if it's causing disruption at school, at work, with your relationships with other people, maybe if you try to stop on your own and have been unable to, so say, okay, I'm going to stop drinking on Monday, and Monday comes around, okay, maybe I'll stop tomorrow. Also, if you have intense urges or cravings to use, that may be a symptom that you have a substance use disorder as well. We go by the DSM-5 criteria to diagnose if someone has a substance use disorder, and that's one of the, you have to have a substance use disorder in order to be in our program, obviously.
So we do a symptom-driven detox here. So instead of just having a set form that says, okay, this person is having issues with alcohol withdrawal, so we're going to give them X amount of Valium, for instance, every person is met with individually, and based on how many symptoms that they actually are displaying and that are observed by the nursing staff, that is how they determine how much medication, if any, is needed during that detox. Obviously, our want is to have people be comfortable, because it's scary enough when you first come into treatment, but then to look at possibly having to detox, it can be a little nerve-rattling. So we want you to be comfortable, but we also don't want to over-medicate people. So because of this, I think we have a much safer, a much more effective, and a faster result with our actual detox. The other thing that is really important is that we have one of the few detox programs for adolescents in the entire country. So we do the same thing with them. It is, again, symptom driven. It's very safe, and it seems to be very effective, and it's been going on for years and years at the PARC. So it's really 100%. Also, the patients that are in detox are able to go to any kind of programming that they're feeling up to. So we do have special programming just for detox patients that help them kind of look at maybe why they ended up coming in here, maybe what we might be able to help them with while they're here. Because really in detox, we want them to just kind of go ahead and go through that process of getting things out of their system, but we want them to have some little tidbits of knowledge just in case they're confused about why maybe they came in.
So we have our day treatment, which lasts about 2 to 4 weeks, and it's all based on the need of the patient. Every week we update their treatment plan so we see where they're at, and our day treatment meets here at our facility from 8 till 4, Monday through Friday. We also encourage our patients to continue their support with our aftercare. So our aftercare is awesome as well. It's another support group. Just like a 12-step meeting is peer run, the aftercare is peer run too. And their aftercare facilitator is really a patient that's been through the program and has completed their year of aftercare as well. So we have a very robust aftercare program. Our intensive outpatient program is pretty neat as well, because we can work, if someone works a 9 to 5 job, we have our evening IOP, which is typically 3 hours a day, 4 days a week. And again, the length of the IOP depends on the need of the patient. Typically, we see about 20 to 25 sessions of our IOP program, and the adolescent program as well, which is really nice because we partner with the Recovery High School as well. So they will come here for treatment for their outpatient program. They will also attend school with the other patients, which is kind of nice because a lot of them, they build their recovery support with their with the other kids that they're in treatment with. So it's really cool to see them all grow, and they really start to hold each other accountable the further along that they're going on in their recovery. So it just warms my heart to see that. But it's really cool because they will go to school here as well as do their intensive treatment with their counselor. So we do process groups as well as CD education. So we're really trying to help them change how they think, really trying to help them, how can I manage my depression? How can I manage my anxiety without using? Because as we know, a lot of these kids will use to self-medicate, they'll use to change how they feel. And when we take away that biggest coping skill, sometimes their mental health does become a primary issue.
So my name is Dr. Kelly Watts. I am a psychologist and resilience coach, and I work often with clients who have experienced trauma. One of the forms of therapy that I use is one of the most popular and research-proven methodologies, which is called EMDR. And Frances Shapiro, who created EMDR, said if she knew how effective and popular it would become, she probably would have given it a cooler name because it stands for eye movement, desensitization, and reprocessing. And what EMDR does, that sounds really complicated, but in fact it's quite simple. The last 10 years there's been an explosion of research around what happens physiologically and specifically in the neurology of your brain when we go through trauma. And in EMDR, or all trauma work really, we think of trauma in two ways. Historically and traditionally, when people think of trauma, they think of some major event, an assault, a car wreck. Veteran experiences obviously often get classified in a traumatic experience list. What we've learned is that those we call big T traumas, and we often have what we call little t traumas. And those are life experiences that we might minimize or not think are as bad because they weren't life-threatening, but they can be similarly damaging, and they have similar processes in our brain in terms of where that information is stored. So over the last decade, and with the advancement of brain mapping and research, we can see what happens in someone's brain when they think about certain things, where certain memories, where your brain lights up when we talk about certain things. And essentially what we've learned is that traumatic memories are stored differently than other memories. And difficult experiences are stored on your right side of your hemisphere of your brain, and the language center of your brain is on the left side. And so that's why talk therapy can be limited. It's helpful with trauma, but it's limited, and there's only a certain amount of healing you might experience. So many clients who have done therapy for many years and found some relief, but not full kind of healing and integration from those experiences, come searching for a different modality. So EMDR clinicians use EMDR, which is a system of activating those memories and stimulating the brain in what we call bilateral stimulation. Again, fancy term to simply mean two sides, we stimulate the right and the left side of the brain so that they talk to each other. So we get those memory networks working and moving in the brain. So EMDR therapists and all trauma therapists usually work with a variety of modalities. And so I might use cognitive behavior therapy and EMDR with a client as we recognize some of the beliefs that have been stored in a dysfunctional way in their brain. So EMDR accomplishes a number of things, and one of the reasons I really appreciate it as a modality is because it doesn't require a client to walk through the details and nuances of a difficult experience. It allows them to activate that part of their brain and move that from a dysfunctional dysfunctional memory to a functional process. So this might occur, for example, if a client had a panic attack while driving across a high bridge. They may then feel like they get panicky or they're scared to even try to drive across a high bridge. And so the body sensations that occur for them, even in anticipation of a similar experience, can be really debilitating. And so we're finding that EMDR is effective for not only the big T traumas, but also for phobias, anxieties, self-esteem and confidence issues, as long as we can focus on a life event that is actually based in your experience, then we can move from there. And what that looks like is, first we get to know each other and talk through, who you are, what you're about. You need to trust me before, obviously, we're going to go into some sort of difficult part of your life. We're going to talk through who you are. We're going to make sure that you don't have any conditions that are contraindicated. So we don't do EMDR with pregnant people because we don't know that it's damaging, but we don't know that it's safe. So we hold fire and wait until that person has had their baby. Also, if you have any sort of seizure disorder or epilepsy like that, moving your eyes in the way that we might use eye movements could be triggering for that seizure disorder. So there are things like that that we consider to make sure that a client is appropriate for EMDR. The other thing we're looking for that is an early phase of EMDR treatment is not even, many people come to EMDR treatment and think we're going to jump right in and do the processing or the bilateral stimulation. And there are a couple phases that we do before that to make sure that a client has the skills to calm themselves. Essentially, I want to teach a client to be the driver of their body and of their neurophysiological experience. So what happens when we have an activating experience is our body goes on hyperdrive and our sympathetic nervous system takes over and tries to protect us from what seems like it's a dangerous experience. And our brain doesn't know the difference between a real experience, a saber-toothed tiger, and an imagined experience of that saber-toothed tiger. And so the physiology of what happens in our body is the same, no matter if it's real or imagined. So it's important that if we do bring up those memories, even in an imagined state, that you have the skills, or a client has the skills, to be able to calm themselves. So we work on physical regulation skills. We work on coping and calming techniques to make sure that that client has the adaptive skills necessary, that if we open up those difficult memories, we're going to be able to pack them away, calm ourselves down, and move through our day between sessions. I don't want to open up anybody's difficult memories and have them feeling really intensely and then send them out into the world in that vulnerable, intense state. So one of the things that many people report back appreciating about EMDR is just the coping skills and formality of walking through coping skills that we do as a preparatory phase. EMDR essentially works with what we call adaptive information processing. It takes memories that were stored and almost get stuck. It's as if you might know someone, or you yourself might have had an experience. We see it, I'm trying to think of everyday examples. We see it in divorce, where someone might obviously go through a hard time, but then years later still be stuck in that difficult emotion around it. When things aren't moving for you, when things aren't getting better over time, then it might be an indicator that some of your memory processes are processes are stuck or frozen and need some help and stimulation to move through to a more adaptive place. Our body has an amazing ability to heal, the same way that if you cut yourself and your body will naturally heal. Difficult experiences are naturally processed, and our brain is wired to place those in an adaptive place. Typically that happens in REM sleep. It's our brain's time to rest and process everything that happened in the day. If we're having a particularly difficult dream and we wake up in the middle of it, for example, then our brain may not have processed all the way through to completion to put that memory into a place that supports us. EMDR also uses the rapid eye movements, but it's different from dreaming. The clinician makes through that the client stays with the memory and with the processing until we're through to take the trauma processing to completion. The last thing we want is to leave you in what I call the dark tunnel. If we imagine going on a train through a tunnel, and EMDR processing often takes us to these dark places, and for a moment it can feel overwhelming. And so I often tell clients we stop at any point that they want to, but let's get to a break in the tunnel so that at least when we're between sessions or you're between processing, then I want you to take a breath and feel a little bit of reprieve. So part of what I think the skill that I'm trying to teach clients when I'm working with them in trauma work is learning to feel their emotions and not be scared of them. The goal is not to not feel sad or not feel scared or not feel upset if you were wronged or harmed or had a difficult time in any way. The goal is simply to not let those experiences drive you. When we've had challenging life events, if those memories are not placed in a productive place in our mind, then we can often be in a state of reactivity. We know that when someone's had a trauma, that their hippocampus actually can shrink, in which case we may be more animalistic and more reactive to triggering events. I saw a documentary one time about physical pain, and it was studying young children who had chronic physical conditions where they needed invasive treatments. And it was challenging the theory that we should have like a built-up tolerance for, if, for example, if a kid was, had to have needles poked in them often as a child, some doctors and parents and people thought this child should have a tolerance and should be really adept at being poked and prodded. And what they found was quite the opposite, that the human physiology is such that those pain receptors get open and they're more vulnerable. And so we think of it very similarly psychologically. When we've been through big T or little t traumas, it can shrink our hippocampus and it can make us more reactive, if not processed, to the point where we feel like we are more vulnerable to triggering and being reactive. And so we want to shift that for people so that they can move through life and feel like they can respond without reacting to everything that's happening to them. They can have an emotional experience, take a breath, sit with it, calm their body, and then choose how they want to respond, verbally, behaviorally, or not respond, right? And feel like they have a sense of control. Oftentimes when people have unprocessed trauma, they describe feeling out of control and feeling like they have outbursts or meltdowns. And sometimes other people can't even tell that that's going on. This might happen internally for someone. But it's a very distressing experience to feel like you can't regulate your own emotions. So that as a result, some people start to avoid emotional experiences. They might avoid relationships. They might avoid things that feel similar to what they've gone through before. And so we don't want that trauma to be depicting what your life looks like. I want you to be in the driver's seat. I want you to decide what things work for you, don't work for you, from a place of grounded confidence instead of a place of reactive avoidance. So there are some questions people ask about EMDR therapy. One of the ones I often get is, will I be conscious and in control? And the answer to that is absolutely yes. Some people associate it with hypnosis, but it is not hypnosis. You are fully aware, you're fully conscious, there is kind of a sense of your brain taking on a bit of a role that feels a bit unusual, if I'm honest. It's the only time in my life when I've participated in EMDR, it's the only time in my life that I can recognize feeling my brain work. And I know that's a bizarre way to describe it, but even after the processing had ended, I could almost feel my brain moving things around. It was a bizarre sense, and it wasn't a physical sense, it was just an awareness I had. So one of the things we know happens for people with traumatic experiences is a disconnection from physiological states. We think this is likely because they get easily overwhelmed, and so then we become disconnected with our bodies. And so EMDR, in its base, is an attempt to integrate our memories, integrate our emotions, and integrate that mind-body connection so that we can really feel like we are in a peaceful space in our lives.